Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
In today's podcast, we'll be discussing various aspects of Alzheimer's disease. We're joined by Dr. Jeremy Prusin. Would you like to introduce yourself?
Sure. Yeah, my name's Jeremy Prusin. I'm a cognitive behavioral neurologist at Banner Alzheimer's Institute and the University of Arizona. I see patients in the clinic. I do a lot of clinical trial research and have my own research interests, which is modifiable and vascular risk factors early in the disease course to try and lower risk for future decline and how they interact with AD pathology.
Great. Thank you, Dr. Prusin. Dr. Vijay Ramanan, would you like to introduce yourself?
Thanks very much. Yes, Vijay Ramanan. I'm a cognitive neurologist at the Mayo Clinic in Rochester. So see patients in the clinic. I help direct our Alzheimer's disease treatment clinic, also involved in clinical trials and research on genetics and blood biomarkers relevant for the disease.
Great. Thank you, Dr. Ramanan. And Dr. Marwan Sabah, would you like to introduce yourself?
Yeah, I'm Marwan Sabah. I'm vice chair and professor in the Department of Neurology at the Barrow Neurological Institute. I too am a cognitive behavioral neurologist that actually does mostly clinical trials, translational research, clinical applicability of new drugs in Alzheimer's.
Great. So our topic will be the diagnosis and staging of Alzheimer's disease. Dr. Ramanan, if we could start with you, over the years, significant changes have taken place regarding the diagnosis of Alzheimer's disease. Can you give us a brief overview of changes that have occurred regarding the approach one uses to obtain an Alzheimer's diagnosis and which guidelines are most often currently used?
That's a great question, Chris. And I think a lot of this just reflects our expanding knowledge about the disease and also the additional tools that we have to help support a diagnosis. One could look back to, years and decades past when an individual may develop at later age progressive cognitive decline, particularly if it was heavily affecting short-term memory. The presumption may be that they have Alzheimer's disease, and through a ruling out of potentially modifiable body issues or intracranial issues, we might leave a presumption that that was the diagnosis and then feel that at the end of life, the analysis of brain tissue under the microscope would be the final say of identifying the amyloid plaques and tau tangles that we know are characteristic of the disease. The field has, I think, in a very positive way, moved more towards early and accurate diagnosis that leverages biomarker assessments that we can deploy during life and deploy in conjunction with those clinical evaluations. And so we can diagnose confidently Alzheimer's disease, be confident about the presence of those pathophysiologic changes of the disease, even during life when paired with a thorough evaluation. We also have a growing understanding of the different phenotypes or the different symptomatic manifestations of the disease. Its most common presentation, of course, affecting short-term memory heavily and early, progressing to involve other cognitive domains as well. But we certainly understand there can be atypical clinical presentations of Alzheimer's disease, which can affect language function, motor function, non-memory aspects of cognition. So I think it's really through research in those areas that the field has shifted more towards define the syndrome of the patient in front of you. Yes, rule out other causes, but yes, also in a thoughtful way, utilize biomarkers to positively help support the diagnosis even before a patient has passed away.
Great. I'm glad you wrote that up. Dr. Sabah, as Dr. Ramanan was saying, there's a prominent role for biomarkers now in the diagnosis of Alzheimer's. Can you tell us a little about the types of biomarkers that are now routinely used to obtain a clinical diagnosis and what the biomarkers tell us, if anything, about the stage of disease?
Yes, so Dr. Ramanan set up the topic very, very well. We are really moving away from a phenotypic description of an Alzheimer patient to a biomarker-driven description using the new criteria that actually comes from Mayo Clinic, the ATN criteria, amyloid tau and neurodegeneration, now in its second iteration, ATX criteria. And so these are driving the field to be defining the disease biologically, not clinically, and deriving from that is the biomarkers that are being deployed, including CSF, PET, and plasma biomarkers. So CSF would be amyloid going down, tau going up. Amyloid PET is now reimbursed and used more commonly than it has in the past, although you use it for the negative predictive value that the label says, not for positive. Tau PET is approved but not reimbursed. We're not using it a lot in practice. And just new in the last year or two is we have the plasma biomarkers, and we're still trying to figure out how to use them in a logical way. I'm using them in a gating tool, meaning that if they're positive, I go on for secondary testing, and if they're negative, I don't. More likely than I'm using them to put a patient in an infusion chair based on a plasma marker. So this is a very rapid change, very, very, very rapid change. After decades of no change, there's been a lot of changes pretty quickly.
Great. So that's those are some great advances in the biological staging. Regarding the clinical staging, Dr. Prusin, can you maybe speak about some of the clinical symptoms one might encounter when diagnosing Alzheimer's at the different stages, and how can you differentiate these symptoms from other types of dementia or cognitive impairment?
Sure. So it's certainly not as simple as it may seem. There are a lot of different factors that can affect one's performance and can push one to diagnose one stage or another, or say that this is normal cognition, and it's frequently not clear cut, and you may get different opinions, especially in more tricky situations where things aren't obvious and clear. So in a simple sense, a dementia, whether it's due to Alzheimer's disease or otherwise, is when there's impairment in function. And that's most commonly starts with instrumental activities of daily living. And in a simplified way of thinking about it, that would be driving, managing medications, keeping a schedule, doing grocery shopping, and those sorts of things. But it's not always so clear cut. For example, if somebody's working and they're, say, an astrophysicist, and they have very mild changes that's preventing them from carrying out their job as a university professor, would you call that functional impairment? Many would. Others would say that, well, that's more the mild cognitive impairment stage. So some of those symptoms we may see where there's been an abnormal change that hasn't affected function, which we call mild cognitive impairment. That sort of stage in between normal aging and a dementia might be more reliant on reminders, occasional but progressive word finding that reaches a level of being abnormal. People become, again, dependent on their phone, but they're able to use their phone to compensate for these subtle but abnormal memory deficits. And we have to take the person and their experience into account. So what are some pre-existing weaknesses? Somebody with ADHD or other developmental weaknesses may look like they have cognitive impairment, but may have been like they are for 10, 20, 30 years, and it's not progressive, and that's not Alzheimer's disease, even though if you maybe compare some of their scores on certain tasks to other people their age or education level aren't exactly the same. So in these cases where it's, especially when it's hard to tell between what's normal aging and what's mild cognitive impairment, we get more extensive memory and thinking tests, a couple hours with the neuropsychologist to really put somebody through the ringer, make more scientific and rigorous comparisons to other people that are similar in terms of age, education, etc. But it's often hard to say, to classify somebody who has complaints that are very subtle as potentially normal, or what we'd call subjective cognitive decline, where they notice some change, but we can't even pick it up on sophisticated testing, versus some abnormal degree of decline. There's also the case where there's clear mild cognitive impairment, where somebody has lost several points on the MMSE, has a very amnestic type presentation, but again are able to compensate in one way or another. The degree of support from family and loved ones also factors into this. If somebody's never managed the finances at home because their spouse has always done so, then we can't use that to try and determine whether or not there's functional impairment. So to kind of summarize, there's normal aging, which is kind of we change normally, processing speed slows down. Perhaps we have very rare occasional word finding versus mild cognitive impairment where there's been abnormal decline that hasn't affected function, and then a more clear dementia stage where somebody no longer can drive, no longer can manage the finances, have difficulty with their medications, and those sorts of things. And that's up to the clinician to really take a thorough history, understand where a person comes from, look at their cognitive testing, and then decide do they need further assistance in kind of determining where a person is on that spectrum.
Piggyback on something Dr. Prusen said, if someone has mild cognitive impairment, dementia, I think the most important next step is to understand what's the cause of it. Is it due to a B12 deficiency? Is it due to a brain tumor? Is it due to Alzheimer's disease? Is it due to some non-Alzheimer's degenerative process? All of those different causes are going to have, in some cases, radically different management options, assuming that a patient does have Alzheimer's disease. Absolutely, we have to be upfront about the idea that we don't have curative or necessarily reversal or restorative therapies for that disease yet, but there are all manner of things that an individual could be considering to try to manage the disease or try to slow down its progression. So there are lifestyle modifications that help keep the brain healthy. These are things that can be implemented really anytime, but we see a lot of research that actually even early and midlife are key times to be protecting the health of the brain to potentially delay or compensate for any changes that may happen in the face of a disease like Alzheimer's. They may be candidates for oral symptomatic medications which help to support cognitive functioning in the face of the disease. They may be candidates for new therapies which try to act on the amyloid plaque process that's involved in the disease as a manner to try to slow down the progression of the disease. Now, none of these options are going to be perfect on their own. Sometimes a patient may invoke multiples of those options into their treatment plan. Sometimes they may even consider enrolling in clinical trials. But in order to get to that discussion and finding the paths that fit for that individual patient, having an accurate diagnosis is key. And so that comes back to, again, seeing someone with expertise in diagnosing these conditions and some understanding of those available options and potentially when to refer if additional expertise is needed. And so these are the discussions that are happening throughout the field to try to expand that knowledge so that for a very common disease, we have the tools and the expertise and the people to accomplish this task.
Dr. Sabah, I wondered if you could comment on something that Dr. Ramanan mentioned. Dr. Ramanan mentioned that there's kind of been a shift towards an earlier diagnosis. Are there practical things that might be implemented in primary or specialty care that might allow for an earlier diagnosis?
I think we're seeing the possibility of a re-engineering of the diagnostic pathway. The consequences that we have seen over the years is that primary care physicians do not feel comfortable making a diagnosis of Alzheimer's, and so they delay it. And they delay referring, and they sit in their practice, and then eventually, years later, they get to refer to specialty care. So one thing that is being discussed with many of these expert panels, advisory groups, is should we be landing specialty testing like plasma p-tau 217, 1A1, A beta 42 to 40 in primary care as a screening tool with an algorithm that if it's abnormal, you refer, and if it's not abnormal, you don't refer. These are the kinds of things that are being discussed. This is not practice yet because we haven't established that quite yet. The other question that has not been established and is being discussed are these tools, these blood-based biomarkers, diagnostic only, or could they be predictive? In other words, could you use them as predictions for future onset or decline or progression? So a lot of things, a lot of knowns and now a lot of unknowns. So I would add a few things to what Dr. Ramanan and Dr. Prusen said. First, if you follow Julie Schneider's work, Brittany Duggar's work, Zoria Ventakis' work, they show that Alzheimer's is actually pure Alzheimer's. Plaques and tangles are relatively uncommon, and most of the diseases overlapping with other diseases like Lewy bodies, vascular, etc. So the reason I bring that up is that we are seeing with the ATN going to ATX, X stand for to be determined, There's interest in vascular, synuclein, inflammation, TDP43. And so we will see the expansion of these multiplex assays to include many more biomarkers than we have now. We're just at the beginning of the biomarker evaluation. And so the question then is, how will we be able to determine if they have more than one pathology? And that's what these assays will allow us to do.
But, jumping off something that Dr. Savard said very well, as we continue to view the disease as a biological entity, and as we continue to understand more about these biomarkers, particularly the plasma biomarkers, how they behave during the course of life, how they behave across the longitudinal course of disease, how they behave in the face of certain comorbidities, could usage of biomarker tests be potentially predictive in the future? Maybe not as a perfect tool, not answering every question in the books, but similar to how one might deploy a hemoglobin A1C or a fasting lipid panel at younger ages in order to triage and guide patients to maybe take certain steps in the future from a preventive standpoint. I think as the disease understanding continues to expand and as our target continues to move earlier, that seems like a natural, possible next step over the coming years to decades.
Great. Dr. Prusen?
Yeah, I think it's a great time to be in the field, and the possibilities are incredibly exciting. One potential application of blood biomarkers may be to say, hey, everybody hits 50 years old, we'll collect a p-tau217 level every 2 years, every 5 years, something like that, kind of akin to cholesterol levels, or maybe PSA, to over time understand what are the trajectories or different patterns, maybe include other plasma biomarkers as well, and kind of look at this profile over time, and is there a change in that profile that suggests there's something going on in the brain that should be intervened upon, and is there a preventative or secondary, if there's already preventative, so primary preventative, do we prevent the buildup of amyloid because it's starting to get there, or do we remove what's already there? When do we start testing? So I think ultimately when and how that looks is to be determined, but I think there will be some sort of model that there will be monitoring through plasma with trajectories of biomarkers that tell us when somebody is at risk and who may need early intervention in order to make the biggest difference in preventing or delaying the onset of symptomatic disease. I think that, in my opinion, is where we're going. Not there yet, and a lot to be learned still.